All right, so what we want to do today is talk about Daniel Callahan's position on euthanasia. Now, why would we care about Daniel Callahan's position on euthanasia and assisted suicide, right? That's an important question. Um, and really, the reason we want to is because, at least in the United States, Daniel Callahan, and I should say the late Daniel Callahan, he just died recently, not too long ago, a few years, I suppose. Um, He founded the Hastings Center back in 1969, and that might be a name you've heard of, or maybe not. I don't think we hear about it as much nowadays as people heard about it throughout the 90s and early 2000s, as all kinds of biomedical issues were being raised, everything from assisted suicide and euthanasia to stem cell research to sort of transhumanism or the beginnings of more serious research and thought into transhumanism, human modification, that sort of thing. So they were busy. All kinds of stuff kind of came out at once, and the Hastings Center was busy working on and commissioning articles and all kinds of research on the ethical issues surrounding these particular topics. Anyway, back in '69, Callahan founded the Hastings Center, which was really the world's first bioethics research institute. And of course, when I'm talking about bioethics, what that's really short form for is biomedical ethics. Although I think the term bioethics now is being used in a more broad sense. Basically, the idea is anything to do with medicine and the relationship of medicine and biological engineering or just biological thought and work. Um, uh, Thinking about those linkings and the issues coming out of that ethically is what bioethics does. And by the way, interestingly enough, here in our own state of Alabama, at the University of Alabama at Birmingham, there is another one of the world's foremost bioethicists that is there, Dr. Gregory Pence. I worked for him for a few years down there, and he does a lot of work. He's written a lot of books. I don't think he's written as many as Callahan has, or 47 books on all kinds of issues that Callahan has written. But Dr. Pence is up there pretty close anyway. This is a very interesting field. It's something that I've been very interested in over the years, and maybe you can tell that by these lectures. Um, as I have gotten into them in this on this particular topic um, of assisted suicide and euthanasia. It's fair to say that Callahan, however, is not a fan of assisted suicide and euthanasia. Indeed, he thinks it's irrational. He thinks it's unethical, it's immoral, whatever sort of negative term you want to use. And he presents his position on it, his feelings about it, in sort of the form of similar to what we've seen right, with other of these philosophers whereas they will put forward arguments and respond to them as to why. Um, that is, they'll put forward arguments that are in favor of these issues, and he will respond to them with his own arguments and criticisms as to why he thinks that those are very short-sighted and very problematic. Let's dig into Callahan's position specifically here. He asks the question, what do we know about suicide? I think really the reason he wants to ask and answer this question is because if we can get a sense of really what our sort of intuitions and thoughts are regarding suicide itself, then that's going to be very informative for how we will think then about assisted suicide, because there's not much of a material difference between suicide and assisted suicide, except that in the latter case, right, somebody is helping you, is assisting you in doing so, whether setting up a machine like Jack Kevorkian did in the 90s in Michigan, or prescribing you um, barbiturates that will indeed um, cause you to die, as they do in places like Oregon um, and Washington State now, I think, and like 13 other states where assisted suicide is practiced, uh, where there are laws that allow it, and it is part of a medical treatment plan, just like anything else in those particular states. So anyway, what do we know about suicide itself? Callahan points out that if you look around at the world, even in your own life, and this is anecdotal, I suppose, but there is data to support it as well. We know that very few people turn to suicide as a way to escape awful lives. And that's just the truth of it. There are people who live very awful lives, very painful lives, very sorrowful lives, um, lives where there's so much that's just wrong that's going on, and yet they don't kill themselves as a way to escape it. Indeed, they don't escape it at all. They, with endurance, get through it, right? So we know that that's true about suicide. It's not a common thing that people do to escape lives that they're living that are pretty awful lives. A second point he makes about suicide, and this is, I think, really an interesting point. He notes that many will say that euthanasia is a rational choice for those with hopeless conditions. And of course, by euthanasia, we're talking about everything under that umbrella. Everything from a doctor actually doing the killing, euthanizing a patient um, voluntarily, we would hope, right, with the patient's consent, or assisted suicide itself as a form of euthanasia. Either way, right, many people will say that this is a rational thing for people to do who live in a hopeless condition, who are in the late stages of a terminal illness, or maybe the early stages of a debilitating illness. And so what they would want to do is end their life before their illness gets really bad, I suppose, or before it progresses, we'll put it that way. Something like Lou Gehrig's disease, or um, any sort of muscular dystrophy or multiple sclerosis, right? Things like this, where in the early stages, right, that things are going to deteriorate over time. And so maybe while you can still be somewhat autonomous and somewhat live your own life, the argument is that, hey, the rational thing to do is end on a high note, right? Cease your life while you still have your wits and your abilities about you. But as Callahan notes, and here he's really getting into sort of the semantics of what rational means, rationality implies behavioral predictability. Rationality means that you'd be able to really predict with some sort of accuracy how people behave, right? Um, but again, with this linked up to that first point now, but we know that very few people do this. So it would be irrational in that sense, right? It's absolutely impossible to to predict with any sort of certainty who would want to, or who would even go the route of suicide as the result of um, difficult diagnosis, and who wouldn't. Let me illustrate this in a different way. And I've used this example before when talking and trying to discuss logic and trying to teach inductive logic specifically. It's the example of the sun coming up. Okay, so um, I think that it is very rational for me to believe that um, not tomorrow, well, yes, tomorrow, but specifically the day after tomorrow. I'm just trying to make this interesting. I think it's rational for me to believe that on the day after tomorrow, the sun will rise. And by that, you know what I mean. The sun actually doesn't rise. It's the Earth spins around and it makes the sun appear as it's rising over the horizon to the east. But you know what I mean. The day after tomorrow, the sun will rise. It will come up. We will have sunlight. It will be over us. There might be cloud cover, sure, but there will be sunlight. Now, that's not happened yet. It's really a guess. It's very possible the sun would not do that 2 days from now. There's no sort of evidence that I can point to that would bring about certainty as to what is going to happen in the future. The best that we can do with things like that is over time, we take evidence from our past experiences and we note sort of reliable track record that certain events have. And of course, the sun coming up every day is a pretty reliable track record. I mean, it's done it for a few thousand years at least. Uh, of recorded human history that's talked about these things and recorded it, doing this. So yeah, I really believe that I'm rational. Why? Because I've got a lot of good evidence, um, such that would support that the sun will come up. Its past reliable track record will do this. That's not the way it is with suicide, Callahan wants to say here, right? If rationality implies behavioral predictability, and this is why it's rational for me to believe that the sun will come up 2 days from now, same thing can't be said about people who live awful lives and want to uh, commit suicide. We don't have this kind of track record. We don't have this kind of evidence to allow us to make any sort of behavioral predictions. Right? Frankly, it's the opposite. I mean, people die miserable deaths all the time without without going to suicide in order to do that. Frankly, the opposite of this is true. That it's more likely that hopeless people will not turn to suicide. The majority of them don't do so. Okay, so it would be more rational to believe that euthanasia is irrational in that sense. Also, think about how that throughout human history, the great traditions of the specifically, I'm thinking of sort of monotheistic religions and various moral traditions have been very influential in Western society, have condemned suicide because it's a very bad way to handle misery and suffering. Right? It just seems to have been a given that as people have lived real lives over the years, they've pointed to suicide as a very bad way to cope with bad diagnoses or tragedies or anything like that. Right? It's just not good. And also, there's this sort of self factor. I don't know if any of you have ever been to a funeral of someone who had committed suicide. Um, those are the worst ones. Those are the most difficult and awkward and frustrating ones because at those funerals, we're not relieved that people have ended their suffering. We're not relieved that they have made their escape. Frankly, I've always felt a little bit of guilt about it. I mean, even those times where maybe the person wasn't super close to me, but I went anyway to the funeral. Maybe I worked with them. I can think of one in particular that I worked with, and uh, you kind of feel like, if I could have just, why didn't I just make a phone call or even just send a text one day? Would that have been all that needed to make the difference, just to make a connection with this person again, uh, to make them feel genuinely, make them feel loved, considered, appreciated. Um, to have renewed my interest in them and in their life. Um, we generally wish they would have died differently than this. So intuitively, there's just something really wrong, it seems like to us, about suicide. This is Callahan's argument here. This is his point about this. So suicide, at the end of the day, just seems extremely problematic. Not the sort of thing that other philosophers, such as Michael Tooley, would argue something well within someone's rights, as if sort of the argument ends there. Callahan is saying is no, that it doesn't end there. There's a lot more going on. Now let's take up those particular arguments, like what Michael Tooley puts out there about one's individual rights being really crucial to uh, being able to choose whatever it is they want to choose, especially suicide. And so what Callahan wants to do now is consider three arguments that he thinks are very bad arguments for euthanasia and physician-assisted suicide. That's what I mean by PAS up there on top, physician-assisted suicide. So what are these arguments? Well, here's argument number one, the argument from self-determination. This is probably one of the more popular ones. And the basic idea here is, of course, this argument that's based on an assumption of autonomy. It's based on an assumption that pretty much you are your own master and you really have no sort of ultimate obligations to others that you don't uh, specifically convey to them, right? You are your own monarchy in a sense. The idea here is that everyone has a right to determine their own lives, and that doesn't involve the public. Now, that seems like a very intuitive argument because, frankly, there's a lot of truth to this in terms of how we live it out. Right? You all are studying to do what you want to do uh, regarding your vocation, regarding jobs and careers later, right? Trying to get some credentials so you can go get a job, make some money, and buy a bunch of stuff, right? The American dream, have a house full of crap. That's what we all want to do, is buy a bunch of stuff. Um, you have the right to choose where you want to go to school. Right? That's your life. Where you want to get lunch or not. the clothes you wear or don't want to wear. Right? I mean, all these sorts of things really are part of what it means to be an individual, that we make our own choices and make our own decisions. Now, does that sort of basic understanding of our individuality apply to this particular topic or this issue of euthanasia and assisted suicide? And Callahan says, well, no, euthanasia really is not a private matter in the way that choosing your clothing is a private matter, although it may not be really exactly true that choosing your clothing is a private matter either. And I think maybe you'll see a reason why here in just a second. So why would euthanasia not be a private matter? Well, because if on one hand, if we legalize it, then it makes it a social act. So the various states in the United States that have legalized it, such as Oregon and Washington, um, and others as well, um, that in legalizing it, it has called upon the public, or at least the public's representatives through their state legislators, to approve this and then to put in place policies in order to govern it, in order to administrate it. Okay, so um, anytime you vote in an election year, right? Go to the polls and you vote, or your state legislator or state senator, um, or your governor votes on this in session, or I guess your legislators would vote on it in session and the governor would approve it or deny it. Anytime they do that, they are doing it by proxy, right? They are representing you, what you want on these issues. And so, with all of these people involved here, it's very much a social act. In our state, if this ever comes up to where we all vote on it, it will be indeed an incredibly social act because we will all be taking part in doing this. So euthanasia itself, then, as it relies upon this sort of or this kind of legitimization um, by the people and their representatives, would make it an incredibly social act. There's other ways we can think about it, though, as not being a private matter. Also, it's a social act by way of medicine itself, as Callahan notes, by implicating physicians, and so also the entire profession is implicated, and associations that regarding medicine and medical research are associated. Um, if this is something that indeed becomes part of what's considered medical treatment, then the entire medical profession um, now has to take part, now has to be involved in how this goes and how this is to be administered and determining what our best practice is, right? So that's definitely not a social matter, because if you would argue that indeed you have a right to this sort of treatment, to assisted suicide, for instance, um, and that your right entails now an opposite responsibility or an obligation on the part of physicians to meet that right of yours, this kind of treatment, then indeed the entire profession is implicated in following through, doing all the work that they would do, that they do on other sorts of things now on this issue of treating via assisted suicide, euthanasia, uh, whatever you want to call it. Um, Interestingly enough, too, I mean, this point would also relate to our earlier one that I just made about social act stuff, because it is the individual states themselves that license physicians, and they have their own medical boards that do so. So those medical boards ultimately are sort of governed by the state, governed by legislatures who put together sort of the bureaucratic associations that run these the professions and license them and stuff. So, and license physicians. So it's very intricately connected. Okay. Now, why is this a problem specifically with physicians and medical practitioners? Well, it's because, as Callahan notes, this would be a very different kind of contractual arrangement between practitioners and their patients. Because for years upon years upon years, I mean, since the beginning of human history, frankly, the practice of medicine has concerned itself with healing people, uh, with with trying to bring them, help them achieve a state of what would be called, right, normalcy or normal. Um, Whatever that is. Or I realize that that's sort of a vague concept at times, but in other words, to not do not make pathologies worse by increasing the likelihood of death. Right? It's medicine has been about healing, not harming, definitely then not killing. So this is incredibly different, incredibly a shift uh, of the philosophy of medicine itself. Also, think about this too. This is a very interesting point, that if euthanasia and assisted suicide are legal, and thus, just like I would contract, and I'm just using that as a sort of technical term here, contract with my particular doctor, and by that I mean I just call and make an appointment, and I sign the waivers and all that stuff, and I go see my doctor. And just like I would contract with him right then, right, to do all that and to pay him to provide me with medical service, like taking my blood pressure, um, checking me out, doing blood work, finding some issues or pathologies, and then setting up a treatment plan to respond and react to those pathologies, to those problems. Just like I contract with him there, if I was to contract with him in order to do this sort of private killing, as Callahan calls it, that we're going to set up a suicide date here or a euthanasia date appointment, because of doctor-patient confidentiality, which is something I appreciate. I think we all do, that we indeed have a very confidential relationship with our physicians, and can keep it so. If we bring in this idea or this practice of assisted suicide and euthanasia as sort of uh, under this banner of doctor-patient confidentiality, then there's no public scrutiny of what's going on, right? There's doctor-patient confidentiality, so there can't be reports written up that describes all the details of what went on and setting up this treatment plan and then carrying it through because of this confidentiality. So there would be no public scrutiny. There would be no um, way for just normal, general, everyday people to really know what goes on here. I mean, it's not as though the patient could live to talk about it on a commercial for that particular barbiturate that they were um, prescribed. So it's a problem. And along with that, Callahan notes that if you think about it, if you think about all of the different vocations and jobs in the world, really it's physicians, it's doctors that know so much about the human body. In a sense, they are too skilled at bringing about death. They know exactly the smallest little thing that can cause death, that can bring about death. And Callahan notes the other side of that coin is that they're hardened at it. They see it all the time. It's just everyday routine. So he seems to think that the temptation to intentionally bring about a death should be kept from them. I think that this is the sort of things that doctors ought not to be allowed to do because they'd be too good at it. And at the same time, death is not as big a deal to them as it is probably to the rest of us. Now, whether he's right on that is an interesting, right? We could argue that. He's not saying that doctors are bad people, that physicians are bad people. What he's just really trying to do there is bring about, or just to make the point that that this is just the way it is. Um, that there aren't trepidations over death with physicians like there would be to the rest of us. Okay, just like for us who drive every day up and down the highway, there's not really as much trepidation for us as there would be for somebody who's never done it, um, uh, and yet knows that people go really fast on the highway. Right? They'd be pretty freaked out. Argument number two. This is an argument that some people make, and what they'll say is that, okay, well, we should have assisted suicide and euthanasia in our society. We should allow people to do this, right, for their sake, to do this kind of treatment plan or whatever you want to call it, really out of compassion and out of love for them, out of compassion for them, simply because we have a duty to relieve their suffering. In other words, we are obligated as a society to help people, to allow them, right, to relieve their suffering. This is a duty that we have. So this is very a sort of a Kantian style argument in that sense. Oftentimes, this is described as a mercy killing. That terminology rarely gets used anymore. That was a term that was used a lot in the 70s and 80s when ethicists were talking about these things. But yeah, it's the basic idea that, you're really extending mercy on somebody by killing them, or allowing them to be killed, having a policy that does so, because that relieves their suffering. Here's Callahan's response to that. He says, well, this is obviously not an absolute duty that overrides all other duties that we have to people. Because if it was a real hardcore kind of duty, then what that would mean is that we just need to go around and start killing people who are suffering. If we really have a duty to these people, then we really need to, uh, we need to, well, how do the mobsters, what were some of the terminology that the mafia uses, or at least that mafia movies use? Uh, oh, I can't think of that word. It's around the tip of my tongue. But anyway, off them. Yeah, that's what it is. We're going to off them. We'd go around offing people. Obviously, that would be a horrific thing to do, and that's Callahan's point here. Right? We obviously don't do that. If this was as big a duty as these proponents say it is, then it would really imply that non-voluntary euthanasia, and maybe even involuntary euthanasia, would be the right thing for us to do. Right? That is to euthanize people um, without their consent, uh, either because they can't give their consent, or maybe even those who say no, they want to live yet they're suffering, but we still, right, still go off them in order to relieve their suffering. That's a problem. And Callahan notes that, when we look at things today and how it are practiced, especially palliative care. Palliative care, that is what that is end of life care. That's specific care, um, in the realm of more or less, right, the last days, the last months of someone's life. So if you're familiar with hospice care, hospice would be a form of palliative care. Um, so anyway, yeah, how palliative care is practiced nowadays, so much better than it used to be. And what we've come to find out is that it really allows for effective relief of people suffering without having to resort to death. That is, resorting to assisted suicide or euthanasia. Um, one of the things that is often said about the assisted suicide debates of the 90s, of the 1990s in this country, um, is that palliative care kind of got its act together as a result of that. A lot of people kind of got freaked out about that. A lot of opponents of assisted suicide got freaked out about it and said, maybe one of the reasons this is becoming a big issue and people are thinking more about this is because we suck at palliative care in this country. So a lot of people took that to heart, and they really started pumping more money into research and resources into making palliative care so much better than it was. And they've succeeded. It is incredibly much better than it was. And Callahan would point to that. He says, the modern advancement in this means that we can relieve people's suffering. We can be compassionate to them, help them in the last days of their life without resorting to death. We don't have to go this route. And the third argument that he responds to is this one that will say that that since there's really no moral distinction between an active euthanasia and a passive euthanasia, right? Um, if we allow passive in some cases, then we should also allow active um, cases of active euthanasia cases. So let me talk about this. Just sort of summarize what this means. Um, Generally, an active euthanasia is described as one in which the euthanasia itself would be sort of the cause of death. The killing, the actual taking of life, would be the cause of death. Generally, this would be the case like Jack Kevorkian's suicide machine. That would be an active euthanasia in a sense, because the patient is actively pushing the button that causes the poison to go through their bodies and kill them. Or in places like Oregon and Washington that have assisted suicide, You go to the doctor and you get your prescription for the barbiturate, and you go home and take it, and you die. I'm actively taking something. I'm actively doing something to cause my death, namely taking that medicine, taking that pill. Passive euthanasia is one um, where the death is caused by disease. Okay. Um, Yet, and this is where I'm going to probably disagree a little bit with Callahan on this slide, and I don't want to confuse you all too much. I don't mind to confuse you a little bit, but I don't want to confuse you too much. Um, a passive euthanasia is one where pretty much we're saying that someone's in the late stages of life, and so we are not going to give them a ventilator. Right? If they go unconscious, we're not going to give them CPR. We're not going to give them any more treatment, any more chemotherapy or radiation or whatever. In other words, we are intentionally withholding treatment. We're withholding medicine, or even withdrawing it, like taking them off of a ventilator, taking them off of life support machine, and allowing them to die. Um, now, now, one of my disagreements with what Callahan's going to say about this turns around the concept of euthanasia, because as we have noted in a previous lecture, euthanasia itself is a death that is brought about because it's thought that the person would be better off dead than alive. In other words, they would get more benefit out of being dead than they would out of being alive, mainly because they're suffering a lot of pain or what have you, right, by living. Now, what somebody who makes this distinction here is going to say um, is that there really is no distinction between. Well, yeah, what they're going to say is there really is no distinction between passive and active. And some people will say that a passive euthanasia is okay, right? Because you're just allowing disease to kill them, right? That's morally okay. And then some people will say, well, but at the same time, an active euthanasia is not okay, right? That's a problem. You're actively killing somebody. That's never okay. Um, and so someone responding to that is who is making this particular argument here. Like passive is okay, right? If you're allowing somebody to die because they're better off dead than alive, then then wouldn't you have an obligation then to actively just kill them, to actually actively, or at least allow them to actively take the pill that would cause them to die, right? You can't have one and not the other. If the goal, if the purpose is the same in both cases, then both should be allowed. Well, here's how Callahan responds to that. There's a major difference here, specifically because passive is death by disease, right? Passive euthanasia is one in which um, someone dies because their disease has taken their life. And active euthanasia is death by doctor. Active euthanasia is where the doctor is the one doing the killing, and that would be the cause of death on the death certificate if that certificate's going to be honest about it. That the reason they died is because they got a shot of potassium chloride, an injection of potassium chloride from their physician, right? And that would seem to go completely against the doctor's entire mission. All right, so why did I say earlier that I disagree with Callahan a little bit here? Well, because Callahan seems to think that, or seems to agree that a passive death is a euthanasia, and I think there's a difference there because again, if a euthanasia is defined as a case where someone dies, or we allow them to die, or we cause them to die um, because they're thought to be better off dead than alive, I don't think that Callahan would agree with that specifically. I don't think here he means to talk about passive death as a passive euthanasia. I think for him, an active euthanasia really is sort of a real euthanasia, a real assisted suicide in that case. But anyway, I'm just sort of quibbling here a little bit because that's what most philosophers do, especially in the morning when we drink a lot of coffee. Okay, but what about hastening death by stopping treatment? Isn't that like killing? And this is a really good question. And oftentimes students will bring this question up because they've had a family member, such as a grandparent or a close friend or something, that has dealt with this, or their family has had to deal with it regarding that loved one. Sometimes, trying to think, my grandfather, my paternal grandfather, some years ago, died of lung cancer, and during the last sort of week or two of his life, he was in hospice care at my parents' home, and he decided he did not want to take any treatment. The cancer had spread. It was a fast-growing one. It metastasized a lot, and just you know, I figured he probably hadn't had it more than 2 or 3 months. I mean, it was a really fast-growing cancer. Um, During the last couple weeks of his life, they were giving him pretty high doses of morphine, which, the morphine itself takes care of the pain, but it also causes respiratory complications. Makes breathing a little bit more, how would I put it, not so much more labored, but lessened, right? It gets you to where you don't even want to care to breathe anymore, right? You're really living the good life in the sense of you are in no pain whatsoever. You are high, literally, on life at that point. And it will hasten death a little bit, just like stopping treatment will hasten death, right? When doctors have to make a determination along with family members on whether to take somebody off of a ventilator machine because they're just not improving and not and don't have any really prospects of improving. Isn't that like killing? Isn't that pretty much the same thing? Uh, and that's a really good criticism to raise here. I mean, isn't giving the morphine like killing in a sense? Because trying to help alleviate their pain, trying to help alleviate their symptoms as they're in their late stages of life, um, it's causing you to hasten their death, bring it about sooner than it otherwise would be. So aren't you really kind of killing them anyway in treatment? Here's what Callahan responds. Here's how he responds to this. He says, well, no, doctors, they stop treatment, indeed. They stop treatment, or they'll prescribe morphine and things like that, not to hasten death, but for a completely different reason. Because that treatment itself, for instance, like the ventilator or like the chemotherapy or something like that, that it's futile. It really doesn't do anything anymore. And it's gotten to a point now that instead of helping the patient, it actually starts harming the patient even more. It actually will start increasing their suffering to a greater degree um, than it was beforehand, when it was actually helping them, when it was actually shrinking the tumor, or when it was actually sort of alleviating pain. Now, what that same treatment is doing is worsening their condition. It's bringing about more pain and stress and more suffering. So that's the reason for stopping treatment. So the motive here is completely different. Reasons why doctors prescribe morphine to late stage cancer patients, the reason why they take patients off of ventilators uh, is because that stuff is just making their life incredibly worse. It's making their suffering worse. It's not helping them at all. So considering the law in euthanasia now, actually, before we get into that, let me ask you, anybody have any questions about any of this so far? We're going to take a little bit of a different turn now for the rest of this lecture, but I want to ask any questions? Questions, thoughts, concerns, anything? I will move on. Of course, if you do have a question, feel free to pipe in, um, shoot a message, or turn your mic on and go to town. We will work on it. Okay, so let's consider the law now in euthanasia. And full disclosure, some of the data and stuff now is a little bit dated that I'm going to use here, because some of is the best that we have without going and doing a little bit more research than I have the time or resources to do. Um, we'll get into that here in a little bit. If we in our state, for instance, if we were to ever have a, how do I put this, a legislation and a policy that governed and guided how euthanasia was to be practiced in our state, Callahan thinks that it would be very difficult to carry out euthanasia law enforcement. He might be right on that. I mean, for the reasons we stated earlier, such as doctor-patient confidentiality. How do you go about investigating these sorts of things, or how do you go about investigating complaints when there's really no witnesses about euthanasia that had taken place? How would the law be enforced, especially since even if a complaint was brought about and potential criminal charges could be brought about, um, doctor cannot reveal anything. At the same time, right, physicians are held in high regard in the public, right? This is a very important position people go to school for many years, have all kinds of experience, and they're very intelligent and educated. Um, how could you really bring about cases against them? They would always have very good arguments and very good positions in response, right? So this would be something that'd be very difficult, very, very difficult to carry out. The other side of that coin, Callahan thinks it'd be very difficult to create a non-arbitrary basis for justifying it, however. I mean, on what sort of moral grounds would serve as a sort of foundation that would justify this kind of practice? If self-determination is the key, and we talked a little bit about this earlier, and if by self-determination, the idea here is autonomy, it's you being able to determine yourself, whatever it is you want to do with your life, if that's the key rationale, is that people have an individual right to do whatever, thus giving you a fundamental right to die, well, then we should really take this a notch further. How is it fair in places like the state of Oregon, the state of Washington, and others? How is it fair that they only limit that to people who have terminal illness? If it really is your self-autonomy, if your individual right is that you have a right to die, how could we limit that to you only if you have a terminal illness? That would be sort of prejudiced, wouldn't it? We would be saying that picking winners and losers in terms of this policy, saying that this only applies to someone with a certifiable diagnosis and not to anyone else. And so we would be denying a lot of people a quote unquote fundamental right to die. It'd be very unfair. And also, if suffering is the key rationale, is a key rationale, I should say. Sorry for the confusion there. That is that not only it's my individual fundamental right that I have as an individual to choose this, but uh, that I'm giving it that I'm meeting the conditions of the state by suffering, right? If the state says, well, we'll only allow people who are suffering to take advantage of this policy and go seek a treatment for assisted, go seek a treatment plan of assisted suicide. And how are we going to gauge what suffering means? Um, is it going to be self-identified? I mean, at the end of the day, how could it not be self-identified? It's not as though physicians can look inside your brain and see suffering, or look inside your emotions and see suffering, engage them, and report back on a form to the state and say, oh yeah, this person is suffering at a level of 8.923, right, on a scale from 1 to 10. No, because this is always something that you identify. Suffering really is an interpretation of pain, or maybe we should put it the other way, right? Pain is sort of an interpretation of how you're feeling regarding all sorts of things regarding yourself. Physical pain, mental pain, emotional pain, right? There's all these financial pain, good grief, right? There's all these kinds of pain, all these kinds of suffering that are going on here, and no one can really talk about the kind of suffering you are facing except yourself. So this would all be sort of self-reported kinds of stuff. Well, if the law is involved, how could that be precise? And these are rhetorical questions, really, that he's noting here, that Callahan is noting, because he's thinking it'd be incredibly difficult, if not impossible, to be really precise with these things. So now let's consider where assisted suicide and euthanasia has been practiced. And one favorite example of a lot of bioethicists is the Netherlands in Europe, right, or Holland, as it's also known. And in the Netherlands, euthanasia is allowed so long as, and these are the conditions that it has in its legislation, it's first of all a free choice. The patient um, has considered what is going on regarding it, and nonetheless persists in requesting this to be done. I think that over there, a patient has to go for like 2 or 3 particular consultations, right? In other words, they have to continually seek it out with a physician. It's got to be due to their own self-described unbearable suffering, and then thus approved by physicians and various physicians who have to consult and unanimously agree that this person is a good candidate for assisted suicide and for euthanasia. Um, in 1990, the government started an anonymous survey that would hand out to all physicians who practiced this, all these different Dutch doctors. And the reason they did this anonymous survey was to see if the results on this survey were different than what the doctors themselves were officially reporting to the government. And what they found was remarkable. First of all, what they found was that about a third of all the euthanasia deaths, which have been approximately about 1,100 deaths, were actually not reported to the government on the official forms and in the official paperwork that doctors sent. So you have 33% of euthanasias that doctors were willing to admit to in an anonymous survey that they did not admit to in the official paperwork to the government. That's kind of scary. Less than 50% of them, right, approximately 1,600 deaths, were reported as a euthanasia. So, right, you got really close to 3,000 that have actually been done, but less than 50% were reported to the government as actually being a euthanasia. In other words, the government was lied to, and they told the government it was due to something else, right? When the doctors just actually euthanized their patients instead and just didn't admit to it. And on the anonymous survey, what they found was that 10% of cases that were considered non-voluntary, that is, people who were in a coma or a persistent vegetative state, and thus they were not able to give consent or not. They weren't able to do it one way or the other. That 10% of those cases were actually of patients that were competent, that could have asked or could have been asked for their consent, but never were. They were just sort of killed without it. Now that's 1990. That's been a long time ago. But the two latest reports then from the year 2000 and the year 2010 show just about the same data, right? They've improved a little bit, but not very much. It's a very negligible difference. That's scary stuff. That's the reason why people like Callahan and others said this would be a disaster to have, because this is the sort of thing that happens. It's really a cultural thing. If physicians indeed are overworked as they are, and if the big business of medicine itself has become so influential, and if in a place like the Netherlands where medicine is socialized, and by that what we simply mean is that it's all paid for out of public coffers, right? Tax money supports it, pays for it, and there's really limited funds, limited resources for that reason. Then these doctors are forced to make these choices, as they argue, and as they argued in some of these surveys, um, that they just had to start rerouting resources where they mattered most, where they mattered more, and get rid of patients who were just consuming all kinds of um, all kinds of resources. It's uh, it's been said. I did look this up many years ago and did a little bit of research on this. That something like at least 50%. I think it's a little bit more than 50%. But at least 50% of all the money that you will ever spend or that will ever get spent on you, like by your health insurance company, over your entire lifetime, about 50% or more of that will get spent on you in the last 2 or 3 years of your life. That's the average in America. So think about when those bills start piling up near the end of your life, if you were to be offed, I'll use my mafia term again. If you were to be offed, think about how much money that would save, how much resources then could be redirected to other people, right? Um, that'd be a very utilitarian way of thinking about it, wouldn't it? What would provide the most amount of good for the most amount of people? Well, it would be to get rid of those people who are starting to use up a lot of medical resources. Of course, people like Daniel Callahan are going to say, no, right? They're going to scream it out loud. And Callahan wants you also to consider the state of Oregon. Back in 1997, in Oregon, they implemented physician-assisted suicide. They legalized it and formed some guidelines to govern how it was to be practiced in that state. Over the years, it's been interesting to see how it's progressed. So look, for instance, at how how many of the medications to kill yourself have been prescribed to people versus how many of them has taken them. So look, in 1998, for instance, um, there is a total of 65. Uh, let me look at this. I got this totally mixed up. I'm sorry. This chart's messed up. Look at these. Look at these numbers backwards. Sorry. In 1998, 44 people were prescribed the medication, the barbiturate, to kill themselves, but only 21 actually took it. Um, Again, in 2001, or a few years later, 21 people were prescribed the medication, but only 16 took it. 2010, 97 people were prescribed the medication, but only 65 of them took it. And in 2017, 213 people were prescribed the meds to kill themselves, the barbiturate that you would, go to Walgreens and get it, take it home, and swallow it down with a glass of Pepsi, and you're all done. 218 people were prescribed that medication and went and fulfilled that medication. Oh, well, I shouldn't say fulfilled. We don't know that. 218 were prescribed it. Only 143 took it. Now, why so few? It's kind of interesting. Why does it seem like, or why is it the case that so many people who actually get the meds uh, don't take them? As Callahan notes, we talked about it a little bit already. Palliative care is extremely good nowadays, especially in Oregon where they have this, and there are so many advocates in favor of life who have really got serious about improving palliative care. That it's good. It's been a very good alternative for people instead of killing themselves. Something that's interesting too that he points out, and I think this is very fascinating, although I'm not too surprised by this, is the real reason for physician-assisted suicide. Okay. Um, and what he's getting at here, and after this we have one more slide to sort of summarize what's going on here. The real reason he wants to bring this up is to show that the original argument that was given many, many years ago for having policies in favor of assisted suicide, um, the major reason, rationale for that is because, hey, people in the late stages of terminal illnesses have a lot of pain. They suffer a lot of pain, and they need a way to relieve that pain. The most effective way to relieve it is to allow them to die, is to allow them to seek their own death in the manner in which they choose. What we find out in surveys that people take in the state of Oregon, at least, and by the way, these surveys are required by the state of Oregon. They require people, they have to fill these out in order to seek assisted suicide. What we find out is that uh, pain is actually one of the least reasons that people choose. Pain is the least reasons why people choose assisted suicide. So, for instance, in 2017, in a 2017 survey given to people who sought physician-assisted suicide, 143 people sought this. I'm sorry, this 143. Yeah, so this 143 would actually be the this is the survey of the 143 people who actually took the meds in 2017. That's what I'm trying to say. So these surveys are the ones of people who actually are dead now. So why did they choose to die in this manner? And 30 of them, and I think this was the sort of thing where they were allowed to uh, pick as many options as apply, check all the boxes that apply, as many as you want, which I think makes this even more interesting. Out of 143, only 30 of them said inadequate pain management. So presumably 113 of them are doing just fine with that, with their pain. Pain wasn't really that big of an issue. So what did the 125 and 126 people say? Overwhelmingly over all the other options say, well, it's that they were concerned with the loss of their autonomy, and they were concerned with the loss of their ability to engage in activities that to them makes life enjoyable. In other words, they weren't able to live the life that they wanted to live anymore. And so since they couldn't live it on their terms, they would rather just die. And that's the criticism that Callahan wants to raise here, right? So pain and suffering was the main reason cited for having a policy of physician-assisted suicide. But what we know now is that it's really not the main reason why people use physician-assisted suicide. It's something deeper about their own uh, definition of their own life and what they think the life is that is worth living or not. Callahan points to a case study that was done some years ago where two groups of people who had similar illnesses were studied. Um, the test group itself, the group they were testing, um, was an interesting group because they were in much better overall health, right? In other words, these were a group of people that had pretty much been healthy all their life. And they were the ones that wanted physician-assisted suicide now. Once they got hit with this particular diagnosis, they wanted it now. The other group, however, uh, had lived or were of people who had lived lives that had suffered a bit over their entire lives. They had all kinds of illnesses and diseases over their entire life. Now they're getting hit with this. They overwhelmingly did not want physician-assisted suicide, which is fascinating. They've got the same illness now, so why did the one group want it and the other group not? It's as Callahan would argue, as the researchers actually themselves argued, that it was because this group that really lived at the top of their game throughout their entire lives had lived a life where they were much more in control of their lives already. And they were really more concerned with autonomy and control, really more concerned with being able to define their lives as they saw fit. And not so much the other group that had endured suffering their entire lives in one form or another. Callahan argues it might really be the case that with that other group, the one that suffered a little bit their entire lives, um, they indeed just could have learned to cope with it. Maybe they just came to realize that autonomy and control aren't the most important things in life, such that if you don't have them, then you can't live, because they've learned how to live and to live good lives and to flourish as best as they could in their lives without much autonomy and control. Callahan concludes then that physician assisted suicide is not about suffering, it's not about pain. At the end of the day, it really comes down to personal values. It really comes down to what somebody believes to be a life that's worth living. As other researchers will say, and other bioethicists have said about this, that really if you define your life, and if anyone defines their life as living sort of the optimum level of life, implicitly what you're saying is that any other life is not worth living. Any lesser life is not worth living. And that will have major implications on how you view other people's lives, right? As Callahan notes, the loss of autonomy is something we all face. It really comes with old age. It's just a normal aspect of life. So physician-assisted suicide really, at the end of the day, is state-sanctioned suicide for those who have a particular conception of the optimum life and its management, which would be one of complete control. It's really what you're saying here, as Callahan argues then, that it's a way that powerful, rich, and if you look at the data that actually kind of supports this, educated people who have been the alpha type A people their entire lives are faced with certitude now that they can't be that anymore, and then just want to end it, just want to call it quits. That's not about pain, really. It's more of a value regarding power and how people think about power, anyway. So that's that.